To our fertility preservation webinar. We're so glad that you've chosen to spend your evening with us. Tonight, we're honored to have Dr. Jennifer Agard here to guide us through the fertility preservation process at Pacific Fertility Center. This is a great opportunity to gain valuable insight and better understand what to expect on your individual fertility journey. Throughout the presentation, please feel free to submit your questions at any time using the chat or question and answer feature. We'll address as many as we can during the session, and typically we'll wait till the end of the slide deck to get questions started. As a special thank you for joining us tonight, we're offering a $99 new patient assessment for those without insurance coverage. This includes an initial consultation and follow-up ultrasound. And it's a great way to kind of lean into the first steps towards understanding your individual fertility options. Um, Without further ado, let's get started, and please join me in welcoming Dr. Agard.
Thank you so much. Hi, as you said, I'm Dr. Jennifer Agard. Welcome to our egg freezing webinar tonight. So I am with Pacific Fertility Center, and we are a group of 4 physicians. There's Dr. Lee, Dr. Ryan, and Dr. Strug, and myself. Let's see if I can change the slide. Here we go. Okay, so just a little bit about myself. I went to medical school at UCLA, and I did my residency in OBGYN on the East Coast. And then I did my fellowship in fertility or reproductive endocrinology and fertility at the Jones Institute. So Howard Jones was my mentor. He and his wife were the pioneers of IVF and had the first IVF baby that was resulted from an IVF cycle in the United States, and they opened up the first fellowship, and they were, basically the grandfathers of our field and grandmother. So super honored. I got to celebrate his 100th birthday with him. So he was an amazing person. I suggest everybody read one of his books. He's great. Or listen to podcasts about him. Okay, so let's get back to you though. Why you're here. You're interested in learning about your fertility and possibly egg freezing. We're going to go over these 5 topics today. We're going to talk about why people freeze eggs and sometimes consider embryos. We're going to talk about how to assess your fertility, what the egg freezing process looks like, and what our success rates are. And then we'll have a little room at the end for some questions. Okay, considering egg freezing. So as you know, a lot of women have continually joined the workforce since 1964, and this goes up to 2010. But women are busy. We're working in one way or another, and we just keep getting busier and busier. This is one reason that people want to freeze. There's also notice that we are delaying having families until later. So a lot of people have made the association that women are working on their careers, working on their jobs, and putting off having families until later. Well, unfortunately, our reproductive systems and our biology doesn't change, even though we've changed as people and what we're doing. And so over the years, we have always seen fertility rates decline as women get older. And here's, the study's been done over and over for 400 years, and it's the same outcome, and it's cross-culturally verified. So women's pregnancy rates are highest when a woman is in her 20s, and that's 20% per month. And as we get older, the pregnancy rates start to decline. At the age of 35, it's 10% per month. At the age of 40, it's 5% per month. And at the age of 45, it's 1% per month. At the same time, the rate of miscarriages drastically increases. For a long time, we didn't know why this curve was this way. It was a point of a lot of contention and debate until IVF was developed by the Joneses and Steptoe and Edwards. And that gave us access to embryos and thus more information about this curve. So in IVF, We get a batch of eggs, we fertilize them with a sperm, and we grow them for a week until they become embryos called a blastocyst. This is a ball of hundreds of cells. The inner cell mass makes the baby. The outer cell mass or trophectoderm makes part of the placenta. Here's a beautiful human embryo. And what we do in IVF now is we take 2 or 3 cells away from the embryo, we freeze the embryo, and we send these cells off for a karyotype. We call it PGTA. A karyotype is the count of chromosomes. So each chromosome has thousands of genes. The embryo gets 1 chromosome from the egg and 1 from the sperm for each type. There's 23 pairs of chromosomes in total. The last set makes the X's and Y's. If an embryo gets anything other than 2 chromosomes per each type, it's too much of a genetic imbalance, and that embryo is typically not able to implant or create a live birth. So they're called aneuploid embryos, and many of them will be the result of a miscarriage. There are some exceptions in medicine, such as Down syndrome, which is trisomy 21, that can make that's an abnormal karyotype that can make a live birth. But for the bulk of these, they generally cannot. So in a study of 5,000 couples who went through IVF and had their embryos tested for a karyotype, what they found was that the percent of embryos with a normal karyotype was linked with maternal age. You can see the orange bars here. The orange bars reflect embryos that have a normal karyotype. We call them euploid. And you can see the curve of the orange bars follows the pregnancy rate of that natural fertility curve. And then you can see the green bars reflect embryos that have an abnormal karyotype. We call those embryos aneuploid. And you can see the curve of the green bars reflects the miscarriage rates of that natural fertility curve. So now we understand why it gets harder to get pregnant as we get older, because it gets really hard to get to a healthy embryo, and why we go through more miscarriages. So there's been lots of studies about everything that can be done to try to delay aging and egg aging, but unfortunately, the only thing that's really worked is freezing either your eggs or your embryos. So our studies at PFC reflect that fertility and sterility uh, publication that I showed you. And so that you can see that these are euploid embryos, and the percent of embryos that are euploid declines with maternal age. And our study extends out to, 47. So that's a lot more information. Okay, so freezing your eggs and embryos is the only way to, preserve your fertility. Okay, so this slide says predicting fertility, but I'd like to call it assessing fertility. How do we assess fertility? Because there are women who have high fertility their whole life and well into their 40s, and then there's women who have low fertility, even women who go through menopause in their 20s and 30s. So how do we assess this? And this is a very common question. So there's lots of different ways that we assess fertility. We assess it by doing an antral follicle count. That's what AFC stands for. We're going to look at pictures of an antral follicle count. We also do testing for an AMH, or anti-Mullerian hormone. So those are the two best predictors of how many eggs we would be able to get in an egg freezing cycle. Predictors of egg quality, this most single best predictor of egg quality is going to be age. But if you're somewhere in the 30s and we're not sure what your quality is going to be, or 40s, we can also do an FSH level. That is another test that helps predict quality of the eggs. Okay, so to kind of back up and explain what ovarian reserve markers are and assessing your fertility, I like to take a step back and explain how the ovary works because the ovary is quite complex. It's a little bit different from assessing a man's fertility. Assessing a man's fertility is doing a semen analysis. Men make sperm every single day, and generally, when a man gives a sample, we see millions of sperm on a semen analysis. We look at the sperm underneath the microscope. We see how many are there, how many are shaped correctly, and how many are moving. And then we compare it to normals. So that's how we assess a man's fertility. To assess a woman's fertility, we can't get your eggs underneath a microscope. So we kind of have these other measures that are not as direct and kind of roundabout, and it's a little bit more in depth to explain what they mean and how they mean something to us. So to explain that, I'm going to go through how the ovary works. So women are born with all the eggs that you're ever going to have. And then after you're born, that's it. That's all the eggs you get. You don't make any more, unfortunately. But women are born with about 1 million eggs in their ovaries, and they're stored in the ovaries as these dormant follicles that can't be seen, they can't be quantified. They're like hibernating. They don't make hormones and they don't respond to hormones. So they're just hanging out there silently in the ovaries until a girl goes through puberty. Then the ovaries become active, and the ovaries select a small group of the dormant follicles and convert them into active follicles. These active follicles are called antral follicles. They are the follicles or the egg sacs that we can see on ultrasound. They're fluid-filled sacs with one egg in them. They are also hormonally active, so they make the estrogen in your body and the hormone called AMH or anti-Müllerian hormone. So that's one of our ovarian reserve tests. These follicles also have receptors for FSH or follicle stimulating hormone, so they can respond to hormones. Usually there's something like 10 to 20 active follicles per ovary each month. So in a normal menstrual cycle, what happens is that a woman's brain makes enough FSH to get one follicle to grow, become a large mature follicle, and then ovulate or release that egg. At the end of the cycle, all those active follicles that weren't selected to be ovulated, the ovaries discard. And the eggs are single cells, so they easily disintegrate. When you get your period, the ovaries select a new group of dormant follicles, convert them into active follicles, and then the process repeats itself again. So this way you are discarding somewhere between 20 and 40 eggs per month, every single month. By the age of 40, you've discarded 99% of your eggs. When we are assessing your fertility, we're checking to see how many active follicles you have per ovary at that snapshot in time. That's not all the eggs in your ovaries. Remember, your ovaries have all these dormant follicles that we can't quantify. But it is kind of that way in a semen analysis. Like, is it a normal count of eggs? Um, and then when we do an egg freezing cycle, what we're doing is just using the normal menstrual cycle and the physiology of the normal ovaries to get the majority of the follicles to grow. So we have you take higher doses of FSH compared to what your ovaries normally see to get the majority, if not all of these follicles to respond, become large mature follicles that we can get the eggs from. Okay. All right, so here's a picture of an antral follicle count. This is an ultrasound that's done by a transvaginal ultrasound. So it's like a wand that goes in the vagina and kind of like a tampon. And we can see the ovaries very clearly. So if you can see, here's a normal ovary. There's lots of little black circles. The black is fluid. So we can easily see the active antral follicles. The ovary has a lot of them, somewhere between 10 to 12 in there. This is a blood vessel here. And then in comparison, here's an ovary that has one clear, large follicle, maybe one here, maybe something there. So maybe, 2 to 3 max in that ovary. So you can tell the difference between the follicle counts. So a low follicle count may imply that there is a low egg yield, right? And that's called diminished ovarian reserve. So both the follicle count and the AMH levels are the best predictors for how many eggs we can get per egg freezing cycle or IVF cycle. Okay, so this is the AMH. We know AMH is highest when we're in our younger years, and then as we get older, it declines. So I always say that age has really a threefold effect on a woman's fertility. As a woman ages, we get fewer number of eggs. A fewer number of eggs have enough egg quality to develop into embryos, and then the percent of embryos that have a normal karyotype declines. So it's not just like age is slowly working on us. We're at this exponential curve because it's a threefold effect. Okay, what can you do other than egg freezing to kind of help your body be the healthiest it can for best egg quality? We know that birth control pills can suppress the ovaries. So if you're thinking about doing an egg freezing or embryo freezing cycle soon, you want to go off those birth control pills and give your ovaries a break from that so that they can kind of revitalize. Being healthy for, having a good BMI and having regular exercise is important to your overall health, and that'll reduce your stress, lower your cortisol levels, and that is the biofeedback that your body responds to. Knowledge of your family history is very important because the best predictor of when you go through menopause is the age of when your mother went through menopause. So, in the spectrum of a woman's lifetime for fertility, the spectrum is that she has peak fertility, then she starts to have declining fertility, such as diminished ovarian reserve, and then she goes through perimenopause and then menopause. The menopause is the time when the ovaries stop producing eggs, right? And it's defined as no period for a year. The age of normal ages of menopause is between the age of 40 to 60. And so then, some women have menopause at the average is 50, some have 60, but there's also a third that go through menopause at the age of 40. So that's really important information for you to have because you know that if your mom went through menopause at 40, then perimenopause is going to happen about, 5 years before that. And diminished ovarian reserve is going to be about 5 years before that. So if you're not ready to have your family and you want to have that option with your eggs in the future, being proactive and preparing for your family in the future is the best way with clearly egg freezing or embryo freezing. Okay, so we're going to go through the egg freezing process, a few steps of this. Again, another huge question that I get frequently is what's the difference between eggs and embryos? So there's a big difference. Remember, eggs are just a single cell, and then that's it. There's no sperm involved. It's just your egg, one cell that we freeze. However, an embryo is an egg that has been fertilized with sperm. It's divided and this is a fertilized egg, and then it divides into multiple cells. It grows for a week until it becomes that embryo called a blastocyst. And when we do embryo freezing, we can take 2 to 3 cells away from the embryo to send off for PGT8 for the karyotype to make sure that the embryo is a viable embryo, has a normal karyotype. So, a few words about, the single cell in the egg freezing process. About 80 to 90% of the eggs survive the thaw, whereas about 3 to 5% of the embryos don't survive the thaw. That means you know, 95 to 97% of the embryos survive the thaw. So there's a much more hardierness to the embryos compared to the eggs. And then we actually have a lot more information about the embryos. Like for the eggs, we know that as once we thaw those eggs, about 90% still have to fertilize, and then they still have to grow into a blast. And on average, that's about 50%. And then, of course, your age at which you froze the eggs predicts the percent of embryos that'll be euploid. So there's a lot of steps of attrition that an egg has to go through to get to an embryo, and we lose a lot of eggs in that process, which is why we need to freeze a lot of eggs for that process to be successful. So some women choose to just freeze, or couples, just freeze embryos because there's a lot more information and the embryo is a lot hardier. However, if there is no sperm around and you have access to a lot of eggs, then that's also a very good option. Okay, so kind of just general broad strokes, talking about what does that look like to get into an egg freezing cycle. Um, what we do is we first see you for a consult, and we need to do your ovarian reserve testing, any fertility testing that we need to do. You have to be tested for some labs before we can freeze your tissue. So there's some lab work that you'll have to get done. You'll meet with our coordinators as a second step, financial team, our clinical coordinators who will kind of go over how to do the injections, have you watch some MedTeach videos, answer basic questions about the logistics, and make sure we get all your labs back and we review them together. When you're ready and you're cleared by your coordinator, then you come in for a baseline ultrasound. So that's an ultrasound to make sure your ovaries are ready to start. Generally, it's around the time of your period, but some protocols vary. After you're cleared to start, then you start your injections. So remember, that's the FSH to get the follicles to grow. This on average happens to be about 10 nights of injections. During that time, we see you for about 4 to 6 ultrasounds. So it's a short time, but it's a little bit intense. So we see you first. First, you do about 4 nights of injections approximately. Then you come in for a check, and then maybe another 3 nights, and then you come in for another check. And then once you get towards the end, it might be every other day or every day, depending on how fast you're responding to the medication. Once the eggs are ready to come out, then we do your egg retrieval. And so your egg retrieval is done under anesthesia. So you will need to have either a friend or family member drive you home because you can't drive after having anesthesia. That day we'll get the egg count and the embryologist will freeze your eggs that day. Okay, just to recap, the injections help grow multiple follicles that are there. There's nothing that can convert the dormant follicles into active follicles. There's nothing that's been shown to do that. All that we can do is get those active follicles to grow. The injections of the medications are used, injected with a small needle. It's kind of like an insulin needle that goes in your tummy tissue. It's not one of those big horse needles that goes into your bottom. Yes, we have injection classes, an amazing staff of nurses and assistants to help us. And again, it's an average of 10 nights of injections. This is a fun one because this is exactly how we do the egg retrieval. So when you're asleep, there is an ultrasound in the vagina, but alongside this ultrasound is a very small needle that goes through the vaginal wall. This is the uterus right here, and into the ovary. And we go into the ovary for both of um, we'll drain both the follicles from both of the ovaries. So here you can see this is the tip of the ultrasound, and then alongside the ultrasound is the needle that goes into the ovary here. And this is the follicle, and then we're going to watch a video here of this happening and draining. So here's that needle, and then it's going into the follicle, and then we remove all the fluid. We aspirate all the fluid, and in that fluid is the egg, and we collect it in this test tube and we give it to the embryologist. and they look at the fluid underneath the microscope and find your eggs. All right. Yeah, success rates. Again, we are very successful. There's a lot of components that go into success rates. Of course, the healthier the eggs are, the healthier the embryos are going to be. We know that when you're younger, the eggs are healthier and have more functional ability to create the embryos. So you can see between the ages of 30 to 34, 30 eggs will give us 90% of one live birth, 70% of two, and even maybe 30 to 40% of three. But as we get older, 30 eggs from 40-year-olds doesn't create that potential. So it may give us a 50% chance of one baby, but very slim after that. ASRM is our governing body, so that stands for the American Society for Reproductive Medicine. Um, ASRM recommends freezing your eggs between the ages of 30 to 35. And that is the kind of best age because that has most success. They did an analysis of uh, women who did egg freezing before the age of 30, and a lot of them didn't come back. Not so it's not as if there's any harm in doing egg freezing before the age of 30. And there's definitely a movement to do so because it's kind of the age of our egg donors. But after 35, we still do egg freezing, but you can see that, yeah, it's less functional, right? You would have to freeze more eggs, or even over here, consider freezing embryos. PFC has been freezing eggs since 2006 in studies, and PFC has been here since the 1990s, so we have a long history and lots of success and have created over 10,000 babies. So we definitely understand what everybody needs, and there's a lot of difference between every single person. Every person is unique. Yes. Common question is there a difference between fresh and vitrified eggs? Once the eggs survive the thaw, there's no difference in success rates in fertilization, blast culture, or euploid rates. And all the studies so far are supportive that babies are healthy, regardless of how they're made, as long as it's one baby at a time. So we are very happy to be the leaders of the single embryo transfer. When you carry one baby at a time, that reduces the risk of miscarriages, reduces the risk of birth defects, and so many other health complications. So we believe very strongly in healthy babies and healthy families. So when you come back after you've frozen your eggs, remember we will warm the eggs. Each step is kind of a little bit of an attrition, right? 80 to 90% of the eggs will survive the thaw. About 89, 90% of the eggs will fertilize with the sperm. And we have to use ICSI. That stands for intracytoplasmic sperm injection. So that's taking one sperm and injecting it into the egg. And then once it's a fertilized egg, on average, 50% of the fertilized eggs grow into blastocysts. So that's kind of a big step of attrition. And then based on your age, somewhere between guessing about 30 to 60% of the embryos will have a normal karyotype. And then we freeze those embryos again, and then we transfer your euploid embryos one embryo at a time. Yeah. Okay, so that's covering egg freezing in a nutshell. Of course, there's a whole lot more involved, and I just kind of talked about the tip of the iceberg here. Again, each person is unique, and if you have something that you wanted to specifically talk about, please schedule a new patient appointment. I'd be happy to see you. We have 4 doctors who'd be happy to see you, and we'll help you on your journey. We do have 2 locations. So there's the San Francisco location and the Marin location. I am most frequently at the Marin location, and this is images of our office in Marin and Greenbrae. Thank you so much for your time this evening. Now it's our time to open it up to any questions that you might have. And
Yeah, we do have a couple questions. The first one that came through is it better to be on the birth control pill or off the birth control pill before starting the egg freezing process?
um, I would say generally you want to come off the birth control pills. Like, for example, if you've been on birth control pills for, say, 10 years, you want to give your ovaries a break off of those birth control pills. If, however, you have timing issues and you need your retrieval to land in a certain time, we can use birth control pills, like a short course of them, as long as you've been off of them. And again, everybody's situation is a little bit unique. Some women with lower, egg counts are going to be a little bit more sensitive to the birth control pills compared to women with larger egg counts. They're not going to be as sensitive. So it's really kind of a case by case situation.
Great, thank you. We have another one that came through, and it is, can you discuss how lifestyle is impacted during the medication slash egg retrieval process and after? Should we expect weight gain, fatigue, etc.?
Thank you. Great question. And I did not talk about that, so I apologize. Absolutely. So, when you're growing all of these follicles, each follicle is like a little water balloon. I call this process a dehydrating process. So, you really need to avoid diuretics. So, that's alcohol and a lot of caffeine. I'd say 1 cup of coffee in the morning is fine, but you don't want to be drinking alcohol. You don't want to be dehydrated. So you want to drink a lot of water. You are absolutely going to get bloated. That's unavoidable. It is a short time. And then, during that time, we want you to stay active because, activity and walking helps circulation, and that'll make you feel better and it'll help keep you healthy during this process. But we don't want you jostling the ovaries. So, like, jumping on a trampoline, horseback riding, maybe even running. We want you to just kind of be protecting those water balloons, supporting your health, supporting your metabolism, but not risking any torsion that might happen. Um, Many women after the retrieval, so during the retrieval, when we remove the eggs, it's as if you've ovulated according to the ovaries, because that's what ovulation is. It's the egg coming out. And so in response, the follicles change from making estrogen to progesterone. In a natural cycle, you have 1 egg that you're making estrogen, and that estrogen in a small amount, we feel good. Our energy hormone is estrogen. It's kind of like testosterone for men. Menopause is no estrogen. Nobody likes that. But if your estrogen levels happen to get super high, like about 5,000, you might start to feel symptoms like fatigue, nausea, brain fog. Um, there's some women get headaches, some women get moody, but usually for most women, they feel okay with the lower levels of estrogen until after the egg retrieval. Then the follicles may convert from making estrogen into progesterone. And progesterone is that yucky hormone for all of us. That's when we feel the worst. This period of that progesterone exposure only lasts until you get your period, which is about 1 to 2 weeks after your retrieval. So for most women, it's the time after your retrieval that you have the most amount of symptoms.
Great, thank you. The next question is regarding accessing the $99 deal. I'll go ahead and answer that. So tomorrow, an email will be going out to you for anyone who's registered and participated in the webinar tonight. We'll be sending out an email. If you want to just actually respond to that email, I'd be happy to get you connected to our new patient services department and we can honor that $99 deal. The next question is, does the male partner drinking coffee or alcohol affect embryo quality?
Yes, it can. So first you want to do a semen analysis. The embryo quality, so the blast rate, the percent of eggs that develop, fertilized eggs that develop into blastocysts, is a function of both egg quality and sperm quality. So the healthier eggs and the healthier sperm you have, the more blasts and better quality blasts that you're going to have. It doesn't affect the percent of embryos that'll have a normal karyotype. Remember, that's only maternal age or the woman's age. But sperm are much more affected by lifestyle factors such as alcohol, tobacco, marijuana, and even caffeine. Again, 1 cup of coffee a day is okay for all men and women in this process. I have seen when a man drinks 10 cups of coffee a day, that starts, that has this very strong negative effect on the sperm. So I would say first check a semen analysis, see where you're at with that, see if it's normal. But yeah, reducing all those factors can definitely help the sperm. And one fun fact is that the worst thing for sperm is actually heat, like above 100 degrees, hot tub saunas. So think about that.
Okay. The next one that came in is in the same way you can gather information or important information about birth defects with a fertilized embryo, can you retrieve the same information about quality with a frozen egg?
Unfortunately, because the egg is just a single cell, we can't do any testing on it. So the only testing that we are doing is testing for the karyotype, the count of chromosomes. And yes, there's certain syndromes like Down syndrome that have birth defects, but birth defects is a huge category, and the majority of birth defects are not related to the count of chromosomes. So just be careful about that. We are using the testing of the embryos to identify embryos that have the potential to make a live birth, right? So that's what we want because we want each embryo to have the best chance of success. So we don't want to transfer embryos that are aneuploid because those will either just not implant or implant and miscarry. There's a couple that can continue to grow on like Down syndrome, and of course we don't have to we don't transfer those if desired, and but the spectrum of birth defects is a big one out there.
Okay, and then the next question is egg freezing an option for women with PCOS?
Absolutely. Yeah, absolutely. So there's no reason why you can't do egg freezing just like anybody else. We know that in PCOS, women tend to get a high number of eggs, which is great and sounds great. However, because of the PCOS, um, metabolic signaling disorder, women with PCOS, the egg quality on average is lower. So women who need help getting pregnant very frequently need IVF. And if you need IVF, then what we tend to see in women with PCOS is that we get a high number of eggs, but a low percent of those eggs actually make it into embryos. So that's one of the things where we, understand that you might get something like 30 to 60 eggs, but you're only going to end up with, 3 to 6 3 to 6 embryos. There's a lot of variation there. So when you freeze your eggs when you're younger, you're preserving, the quality that you have because of your age. Because women with PCOS, their egg quality is going to age just as much as anybody else without PCOS.
Okay, and then the next question is, would we have access to this video? And the answer is yes. In that email that will be sent out to you with your with the $99 special, it will include the video as well. And the next question is, are there any genetic diseases that can develop after the transfer? Are they frequent and can we test for those?
Yes, we can test for them. So we test for expanded carrier screening panels. So it's a panel of about 600 mutations. They're recessive genes because recessive means that you're just a carrier, but you don't have the disease. If on the opposite side of that is dominant genes, that means that if you have one mutation, then you're going to have the disease. So you'd already know by now that whether you have a disease or not. So we screen for recessive, no need to screen for a dominant. And we screen for recessive mutations that cause, early childhood disease. So the most common cause of single gene mutations that cause birth defects. Yeah, we absolutely recommend that, and we have you review your carrier testing with genetic counselors. We have a full panel of genetic counselors that you'll be working with. Most people are positive for a few of these because they're recessive. But the important thing is that you and your partner are not both carriers for the same mutation or the sperm donor that you're using, if that's the case. So, yeah, we do that.
Okay. And then the last question is, what is the cost? I'll go ahead and take this one. So part of the process with getting your fertility workup is actually meeting with one of our financial coordinators. And what they will do is they will assess your insurance coverage if you have it, or if you're just doing it out of pocket. It will be specific to your treatment plan following the ultrasound that you have with the first ultrasound that you have with your physician. For general costs, you can find that on our website, just as like a, quick reference. But we do go and, do a deep dive for each patient after that initial ultrasound visit.
Yeah.
Okay. Well, that concludes the questions.
Great questions, everyone. Thank you so
Yes.
much.
Um, Well, with that said, thank you all so much for joining us this evening. We hope that you found the presentation informative and helpful as you navigate your fertility journey. I encourage anyone who's interested, or who's joined us tonight and interested, to reach out to info@pacificfertility.com. And like I said, we'll be sending over the email with the video recording. You're welcome to just respond to that email, and we can go ahead and get you set up for a consultation. If you have any follow-up questions, you're also welcome to reach out to the info@Pacific Fertility email. And you can also give us a call at 415-834-3095. We're here to help, so just anything that you need. And on behalf of everyone at Pacific Fertility Center, thank you for spending your evening with us, and we wish you a wonderful evening.
Thank you. Good night.
Thank you, everybody. Bye-bye.